everyone. Welcome to today's Public Health Ontario Rounds on seasonal respiratory virus immunizations for the 2025-2026 respiratory season. Next slide, please. So my name is Dr. Sarah Wilson. I'm the Deputy Chief of Communicable Disease Control here at Public Health Ontario, and I have the great pleasure of moderating today's rounds. Before we begin today's session, I want to take a moment to acknowledge the land on which we live and work. I am moderating today's rounds today from Toronto on the traditional territory of many nations, including the Wendat, the Anishinaabe, the Haudenosaunee, and the Mississaugas of the Credit. This land is part of the Dish with One Spoon Wampum, an agreement to share the land and care for it together in peace and respect. As we gather for today's rounds, it feels fitting to reflect on how immunization is also an act of shared responsibility, one that protects not only ourselves, but also those around us. And this idea of collective care echoes Indigenous teachings about interdependence and reciprocity. Next, I'd like to just mention some very brief housekeeping items. To ensure an engaging and optimal experience for everyone, the Zoom chat and audio-video features have been disabled for this session. But please do submit your questions for the speakers in the Q&A function. This should be found at the bottom of your window because we'll be sure to address these in the interactive portion of the rounds following the presentations. Next, I want to acknowledge that we certainly recognize the interest of our audience in accessing the presentation and the recording of this session. And PHO aims to provide this on our website as soon as possible while still ensuring that we meet the accessibility requirements of our audience. So stay tuned for this posting. And then finally, for any technical issues that may arise, hopefully none do, but if you do encounter those during the session, please feel free to email capacity building, so all one word, capacity building at oahpp.ca. So next, I'd like to just briefly highlight the learning objectives for this session. You can see them here on the slide, but we're hoping that by the end of this session, that participants will be able to describe the immunization products available in Ontario for the 2025-26 season for COVID-19, influenza, and RSV, to summarize the NACI, National Advisory Committee on Immunizations recommendations, as well as provincial guidance for these programs. And then finally, we hope that participants will leave the session knowing where to locate resources to support their practice in the delivery of these three important programs. Next slide, please. So it's my great pleasure to introduce the speakers today, Dr. Reid Morrison, Dr. Adrina Zong, and our panelist, Dr. Daniel Warshafsky. Dr. Reid Morrison is a public health physician in communicable disease control at Public Health Ontario, where he supports the immunization and vaccine preventable diseases team, as well as the communicable diseases team. He's an assistant professor at the Northern Ontario School of Medicine as well. Dr. Adrina Zong is a public health physician in communicable disease control at PHO, where she supports the communicable diseases team and the enteric, zoonotic, and vector-borne diseases team. And then finally, our panelist, Dr. Daniel Warshafsky, is an Associate Chief Medical Officer of Health, and he oversees the immunization portfolio in the Office of the Chief Medical Officer of Health at Ontario's Ministry of Health. And he is also an adjunct lecturer at the University of Toronto and an adjunct professor at the University of Ottawa. And then the next slide, please. We'll just note that none of the presenters, none of the panelists, and neither myself as a moderator, none of us have any conflicts of interest to disclose before we get going with today's presentation. So with those introductions and housekeeping notes covered, I'd like to now hand it over to my colleague, Dr. Reid Morrison, and he'll take us through the next and the first presentation. Thanks very much, Reid, for kicking us off.
Okay, thank you, Dr. Wilson, and we'll move to the first slide. So I will start by highlighting that COVID-19 continues to have an important burden of disease. We can see from this line graph of COVID-19 and influenza bed occupancy that COVID-19 had a significant burden from the late summer to midwinter of last season. And having said that, the green arrows above July of each of the past 3 years help illustrate that, while a clear seasonal pattern has not emerged, periods of increased COVID-19 activity have overlapped with other respiratory viruses in the fall and winter. Next. The burden of disease is particularly significant in older age groups. In the left-sided line graph of case counts over time, we can see that those over age 80, followed by those age 60 to 79, are responsible for far more cases than other age groups. This is even more pronounced when looking at the right-sided line graph of hospitalizations, which demonstrates that the significant burden faced particularly those aged 80 and over. And next. SARS-CoV-2 viruses continue to evolve over time, leading to the emergence of new variants and lineages. Some variants acquire changes or mutations that enhance virulence or transmissibility, or allow the virus to escape immunity provided through prior infection or vaccination. So as variants continue to evolve, it's important that COVID-19 vaccines are updated annually to provide the best match against the currently circulating strains. This season's COVID-19 vaccines will target the LP.8.1 lineage. The figure seen on this slide is taken from PHO's SARS-CoV-2 genomic surveillance in Ontario report, and it illustrates the relationship between the most prevalent SARS-CoV-2 lineages in Ontario between August 17th and September 13th. The lineages branch from left to right, and the most prevalent lineages are filled in gray. Next. So vaccine effectiveness depends on several factors, including age and health status, the match between the vaccine strain and circulating viruses, prior infection, and the number and timing of prior COVID-19 vaccine doses. In general, we expect increased protection with more recent vaccination and a COVID-19 vaccine that more closely matches the circulating strain. Studies from last season demonstrate that COVID-19 vaccines were protective against outpatient visits and hospitalizations, including in those aged 60 and older. In this age group, vaccine effectiveness was in the low 40% range against hospitalization. And just to say, incremental vaccine effectiveness is a measure that captures the added benefit of vaccination in populations that already have immunity from high rates of previous vaccination or infection. Next slide. For the upcoming season, NACI has continued to strongly recommend COVID-19 vaccination for individuals at increased risk of infection or severe disease, and have recommended that all others may receive a COVID-19 vaccine dose this fall. New to this year is that NACI is now referring to a minimum interval between vaccine doses of 3 months to support flexibility in the timing of vaccination. And similarly, individuals and immunizers may consider delaying vaccination by 3 months if they have a recent test-confirmed SARS-CoV-2 infection. Next slide. So for those in Ontario, the next few slides will summarize this season's COVID-19 vaccination program. To support implementation, immunization recommendations are described for each of the high risk or priority or general population groups seen here. I will highlight now that those not captured in the high risk or priority populations may receive a dose starting on October 27th. Next. Adults aged 80 and older, those living in long-term care homes or similar settings, those over 6 months who are moderately or severely immunocompromised, as well as those who identify as Indigenous or their household members over age 55, are at increased risk of COVID-19 disease and severe outcomes, and should receive a COVID-19 vaccine dose as soon as it becomes available in the fall, and should receive an additional dose in the spring. The slight exception to this is that those aged 65 to 79 may, as opposed to should, receive a spring dose. Next slide. Those in long-term care settings who are under 17, people with underlying medical condition, pregnant persons, and those who identify as Indigenous 54 years and under, as well as members of underserved communities and healthcare workers, are at increased risk of SARS-CoV-2 exposure or severe COVID, and should receive a COVID-19 dose as soon as it becomes available in the fall. And next. Children 6 months to 4 years of age and individuals with significant exposure to birds or mammals, so for example, veterinarians, those who work with poultry or livestock or wildlife officers, may receive a dose as soon as COVID-19 and influenza vaccines become available this fall to optimize co-administration. And as mentioned earlier, those who have not been captured in these high-risk or priority populations may receive a dose starting October 27th. Next slide. So there are 2 mRNA vaccines available this year in Ontario. You'll see here that the Moderna product is available for those 6 months and over, while the Pfizer product is available for those 5 years and over. There are differences between the products in terms of dose by age group, but 1 dose is recommended for those who have been previously vaccinated, and as described, should be at least 3 months since an individual's last dose. Next slide. So I encourage everyone to refer to the very helpful Ontario fact sheets for healthcare providers, as there is some pretty detailed information on this in the next slide. But overall, for people who are not previously vaccinated, there are different schedules for those who are or are not immunocompromised. For those who are not immunocompromised, a single age-appropriate dose for those 5 years and older is recommended. For those 6 months to 5 years, 2 doses separated by 8 weeks is recommended. Next slide. So for those who are immunocompromised, an age-based approach is recommended with 3 age-appropriate doses for those 6 months to 5 years, and 2 doses recommended for most people 5 years and over. An exception here is for those who have received HSCT or hematopoietic stem cell transplant or CAR T cell therapy, where 3 doses can be considered. Next slide. And these are just some of the resources that I've mentioned or we encourage people to check out. And I will pass over to Dr. Adriana Zung.
Okay, thanks so much, Reid. So I'll take us through for the seasonal influenza vaccines. So just want to start off by highlighting that influenza does cause a significant burden of disease for the Ontario population. And this figure here on the slide just showed that hospital bed occupancy rate for different age groups for our seasonal influenza season last year in Ontario. And as you can see, overall, adults 65 plus are by far the leading age group when it comes to hospital bed occupancy. But also children under 5 years are actually the second highest age group. So it's important that we try to maximize vaccine uptake, especially in these high-risk groups, to prevent a lot of these severe outcomes that we see across the population. So each year, NACI issues a statement on seasonal influenza vaccines. They do recommend that all individuals 6 months and older should receive an annual dose of the seasonal influenza vaccine. In addition, there are specific groups for whom vaccination is particularly important, and these include people at high risk for influenza-related complications, people capable of transmitting influenza to those who are at high risk, and 2 additional groups that include people who provide essential community services, and lastly, people whose occupational and recreational activities increase their risk of exposure to avian influenza viruses. And just to elaborate a little bit on that last group, so this is a new group that NACI has expanded the recommendation to, and this is following recent increases in avian influenza outbreaks amongst poultry and mammals with transmission seen to humans in the US. And so I just want to clarify that seasonal influenza vaccine does not protect against avian influenza infection, but they may reduce the risk of co-infection of both viruses, and that may reduce the disease, reduce the severity of disease, but as well as the possible viral reassortment of these viruses. And so in Ontario, we have the Universal Influenza Immunization Program, or UIIP, and the guidance in Ontario here is based on NACI's recommendation. So here we have the definitions for the high-risk population as well as priority population, and these groups should or may receive the vaccine as soon as it's available this fall, which I believe is being rolled out right now. And as you can see, it does align very closely with NACI guidance, and there's also alignment with what Dr. Morrison outlined in terms of the COVID-19 vaccine program eligibility, and that's to better facilitate the co-administration of both vaccines this fall. In terms of the general population, so those who do not belong to the previous two groups, the seasonal influenza vaccine will be available starting later this month on October 27th. And amongst this group, Ontario particularly recommends two groups to receive the influenza vaccine, and this would include individuals capable of transmitting influenza to either infants under 6 months or anyone who is deemed priority group to receive the vaccine, as well as those who provide essential community services. So this year is the first year that Ontario will be transitioning to using trivalent influenza vaccines, which refers to vaccines that contain 3 strains of influenza virus. So this is following the WHO recommendation to remove one of the influenza B strains, the B Yamagata lineage, from vaccines, since we have not seen this lineage circulate globally since March 2020. NACI has also supported this recommendation, and so this year the vaccines that we have on the market and also in Ontario here in our program does align with this global transition to trivalent vaccines. And so this table here shows the 3 strains that will be in this year's vaccine products. And this is from WHO, who meets ahead of the influenza season to determine the strains and updates as needed to better match what will be circulating in the upcoming season. And as you can see, the H3N2 component of our influenza A strains has been updated to better match, hopefully, what will be circulating. In terms of the vaccine products that are available in Ontario this season, so we do have several different products that are all inactivated influenza vaccines. And just a reminder that Ontario offers free influenza vaccine to anyone over 6 months who lives, works, or goes to school in Ontario. There are several different standard dose vaccine products for anyone 6 months and over. And for those who are age 65 and over, in addition to the standard dose products, there is a high dose vaccine product and an adjuvanted vaccine product also available for those individuals. In terms of selecting a vaccine product for that age group that is 65 and over, so following NACI guidance, either the high dose or the adjuvanted product should be offered over other age-appropriate products. However, if the preferred product is not available, then any of the products, including the standard dose vaccine, should be offered. This is based on NACI's review of the evidence that shows the high-dose vaccine, which contains a higher antigen content, does improve the immune response compared to the standard dose in those 65 and over. And an adjuvanted product also helps the recipient mount a stronger immune response compared to unadjuvanted. So bottom line, high dose and adjuvanted should be offered to 65 plus and preferred over standard dose, but if they're not available, it's important to not delay vaccination or risk missing the opportunity to vaccinate these individuals, and standard dose, of course, can be offered as well. In terms of the vaccine schedule, this has not changed from previous guidance. So for children who are 6 months to 9 years of age, if this is their first time receiving influenza vaccine, then 2 doses are required. But if they have received any seasonal influenza vaccine before, then they just need 1 dose this season. And for those who are 9 years and older, only 1 dose is needed this season, regardless if it's their first season or not. And just to emphasize that it is important to get an annual dose of the influenza vaccine because, as mentioned before, it does change year to year depending on the strains that are included and how well that strain matches the circulating influenza strains that we'll see. And there are additional benefits beyond just protecting against influenza infection and severe illness, such as benefits in protecting against other infectious diseases, including invasive group A streptococcal disease or IGAS, and also benefits benefits in protecting against exacerbation of chronic diseases such as cardiovascular disease. And one additional consideration that is new to Ontario this year is that Ontario has implemented a human vaccination against avian influenza program. And this is with the Arepinrix H5N1 vaccine. So following NACI guidance, we have been offering a Arepinrix vaccine to eligible individuals in Ontario who are assessed to be at the highest risk of avian influenza infection. And so this would include people with ongoing contact with birds likely to be infected with avian influenza, as well as people who handle live avian influenza virus in laboratory settings. And so local public health units have been administering these vaccines to eligible individuals over the summertime. And the reason why this is important and relevant for the seasonal influenza vaccine is that NACI does recommend that there should be an interval of 6 weeks between a dose of Arepinrix and any other vaccine, including the seasonal influenza vaccine. And I do want to highlight that the 6-week interval is not due to a vaccine safety issue or contraindication, but rather it's in place so that any adverse event following immunization can be more accurately attributed to the appropriate vaccine. And so here are some additional resources just for your reference. And I will highlight that the healthcare provider fact sheets from the Ministry of Health have great summaries on all the different vaccine products. And I'll hand it back to Dr. Morrison to give an overview on RSV.
Okay, thank you. Move to the first slide. So RSV is a major cause of lower respiratory illness, particularly in infants, young children, and older adults. This line graph of hospitalization rates by age group helped to demonstrate the significant burden of hospitalization among those age 0 to 4 in the red line and those over 65 in the blue line. However, due to the large population size of the 65 plus age group, the overall number of hospital beds occupied is largest in this group. Older adults, particularly those with existing comorbid conditions, are more susceptible to severe disease and have an increased risk of RSV-related hospitalization and mortality. Next slide. There are 2 RSV vaccines available for older adults in Ontario this year: the adjuvanted protein subunit vaccine by GSK and the bivalent protein subunit vaccine by Pfizer. A third mRNA vaccine by Moderna is also authorized by Health Canada. The GSK and Pfizer vaccines are both indicated to prevent lower respiratory tract disease in adults over age 60. The GSK vaccine is also authorized for adults 50 to 59 at increased risk for RSV disease. And the Pfizer vaccine is also authorized for pregnant individuals to prevent RSV disease in their infants. And I'll discuss that a little bit more later. Next slide. So overall, the RSV vaccines available in Ontario have been shown in real-world studies to provide protection against severe RSV disease, both in the general population over age 60 and in people who are at higher risk of severe RSV disease. In real-world settings, vaccine effectiveness has been very similar to clinical trial findings, and there's no meaningful difference between the 2 products. A common question for RSV vaccines in older adults is about the level of protection over time and how this may influence potential future doses. And so while this is an area of active investigation, the best available evidence does show multi-year protection with some waning over time. Most importantly, for those who will be immunizing, is that an additional dose of RSV vaccine is not currently recommended for those who have been previously vaccinated. The vaccine safety data gathered by post-marketing surveillance aligns with the safety profile found during clinical trials. Of note, following a safety signal showing potentially higher Guillain-Barré syndrome in clinical trials of the 2 RSV vaccines used in Ontario, a post-marketing study of RSV vaccine safety was conducted in the United States. Overall, this found very small but higher than expected rates of GBS reported in those who were vaccinated compared with those who were not. Importantly, because of the nature of the study, such as the voluntary nature of vaccine safety reporting, causality cannot be assessed in this context. Next slide. NACI has two categories of recommendations for RSV vaccines in older adults. For public health programs, NACI recommends RSV immunization programs for those over 75, especially those who are at increased risk of severe disease, and for those over age 60 who are residents of nursing homes or similar facilities. At an individual level, NACI recommends that individuals between ages 50 and 74 could consider an RSV vaccine after consulting with their healthcare provider. Next slide. The Ontario Older Adult RSV Prevention Program has been expanded this year to include all individuals age 75 and over. In addition, those who are age 60 to 74 and belong to one of the groups identified here are also eligible. This includes those who are residents of long-term care or similar facilities, those with certain comorbidities, and those who identify as Indigenous. As mentioned, an additional dose this season is not required for individuals who have previously received an RSV vaccine dose. Next slide. So switching gears, there are two products available in Ontario to prevent RSV disease in infants. The monoclonal antibody nirsevimab, administered to infants and high-risk young children, and the RSV pre-F vaccine, administered to pregnant individuals to protect their infants after birth. Next slide. The monoclonal antibody nirsevimab is administered to infants to provide direct and immediate protection. It's recommended in the month before and throughout the RSV season and provides protection for up to 6 months. The RSV pre-F vaccine is administered to pregnant individuals between 32 and 36 weeks who will be delivering during the RSV season. It takes about 2 weeks for antibodies to form in the parent and to be transferred to the infant before birth, and protection lasts up to 6 months from birth. Next slide. Clinical trials and real-world studies have found nirsevimab to be very safe and effective in infants during the first RSV season. Studies of product effectiveness have found protection against hospitalization to be 80% or higher. Similarly, studies have demonstrated that the RSV pre-F vaccine has been effective against hospitalization and severe RSV disease between birth and 6 months. Both the nirsevimab product and the RSV pre-F vaccine have demonstrated a good safety profile. However, as with any medication, there rarely may be some side effects, which are generally short-lived and mild to moderate in severity. A RSV pre-F clinical study did identify a non-significant imbalance between immunized and placebo groups for preterm births and gestational hypertensive disorders. Post-marketing surveillance studies in the United States have not found an association with preterm birth. Other post-market studies have found a small, statistically elevated risk for hypertensive disorders, including gestational hypertension in those who have been vaccinated. Next slide. So NACI recommends that provinces and territories build towards a universal RSV immunization program using nirsevimab for all infants. At an individual level, NACI recommends that RSV pre-F vaccine can be considered by pregnant individuals in discussion with their healthcare provider. Next slide. This will be the second season of the expanded RSV prevention program in Ontario. All infants born April 1st, or I should say born after April 1st, who are less than 8 months of age will be eligible up to the end of the season. For children up to 24 months of age entering their second RSV season, certain conditions listed here may mean that they remain at increased risk for severe disease and would be eligible for a second season dose of nirsevimab. Next slide. In Ontario, nirsevimab is recommended for infants under 8 months entering or born during their first RSV season. If nirsevimab is anticipated to be administered to a healthy infant, then the vaccine during pregnancy may not provide additional benefit. Pregnant individuals and their healthcare providers should discuss the use of the RSV pre-F vaccine in cases where nirsevimab would not be accepted or be available, such as not giving birth in Ontario. Next slide. However, if the RSV pre-F vaccine is used in pregnancy, there are some circumstances when nirsevimab would still be indicated, including when the infant is born less than 14 days after the vaccine was administered, or when the infant would be at higher risk for severe disease. Next slide. And as before, we encourage everyone to review these very helpful resources. Next slide. So surveillance is a key component of vaccine safety, and I will thank all the healthcare providers attending today in advance for supporting vaccine safety by reporting adverse events following immunization to their local public health unit. An APHI reporting form is found on the PHO vaccine safety webpage, and I encourage everyone to check the website of their local public health unit for reporting instructions and details. Next slide. A quick note that because nirsevimab is not a vaccine, it is not subject to the mandatory reporting under the Health Protection and Promotion Act. Providers are encouraged to report any side effects from nirsevimab using the Health Canada side effect reporting form. Next slide. So lastly, we would like to highlight that COVID-19, RSV, and influenza vaccines can be safely co-administered. As inactivated vaccines, they can be administered with or any time before or after other vaccines. For adults 65 years and older, there are no direct studies on the co-administration of Shingrix with Fluad, or as we mentioned earlier, the trivalent adjuvanted influenza vaccine. However, vaccinations should not be delayed to obtain a non-adjuvanted influenza vaccine if co-administration is planned. As a monoclonal antibody, nirsevimab can be administered at any time before or after routine childhood vaccines, including live vaccines. Next slide. And at this point, I will pass back to Dr. Wilson for the Q&A portion.
Okay, excellent. Well, thank you so much to both of our presenters. Thank you, Dr. Zong. Thank you, Dr. Morrison, for the excellent presentations. And I'll invite our panelist, Dr. Daniel Warshafsky, there he is, to come on screen as well. So this takes us now to the interactive portion of our rounds today. There are a few questions that are already entered into the Q&A functionality of Zoom, but I certainly encourage all of our participants to continue to post questions there. We have ample time to work through them and encourage all participants to add their questions there. So I'm going to start first with a question that Dr. Adrina Zong, I think, is best answered by you. It's in reference to a comment you made in your delivery of the section on influenza vaccination and its potential additional benefits beyond just prevention of influenza. So there's a question just there around if you can clarify about your comments about how the vaccine may protect potentially against invasive group A strep infection. So can I turn it over to you for that question? Thanks.
Thanks, and thank you for the question. So yeah, I guess I will start by clarifying that the influenza vaccine offers direct protection against influenza infection. There are indirect protections for some other to allow for some other benefits as well. And so we do see in invasive group A strep cases that having a recent influenza infection, as well as recent varicella infection, these are risk factors for developing a more invasive picture leading to invasive group A strep infection. So there is that association there with influenza. And so by getting influenza vaccine and protecting against an influenza infection, we can then hopefully protect secondary outcomes from that, including like secondary bacterial infections, which can possibly be group A strep as well.
Thanks very much, Adrina. Very helpful. Okay, next we're going to go to, there are a few RSV questions. So Dr. Morrison, I'll turn these over to you. So one of the questions is, my interpretation of it is it's in reference to the RSV vaccine program for adults, and it's asking for clarification on the schedule. So if someone's been previously vaccinated with an RSV vaccine, are there any recommendations for that person for this season? The question is there a time frame in which you might offer an additional dose? Do you have any perspectives on that?
Yes, thanks. And thanks for asking for the clarification. So this refers to any previous vaccine dose received in any previous season. And so we do have good evidence from clinical trials that there is multi-year protection, so up to 3 years right now. And so this would cover, for example, individuals who may have received the vaccine when it came out, for example, 2 years ago or last year. And so anybody who would have received a dose in previous seasons does not require another dose this season.
Excellent. Thanks so much. So there's a second question on a related theme. So this is now asking about RSV vaccine in pregnancy. And it's a question about whether or not RSV vaccine in pregnancy should be offered with additional subsequent pregnancies, or should it only be offered once?
Yes, right now there is no indication to offer RSV pre-F vaccine in subsequent pregnancies if it has been offered already. So what that means is that if a pregnant person has received the vaccine in one pregnancy, right now there is not an indication to provide in subsequent pregnancies. There is, having said that, there is a trial ongoing to look at it, exactly this question called the Marguerite trial. And so like a lot of the questions revolving around RSV vaccine, there is, active investigation, and we will know and hear more in the coming months and years.
Thanks very much, Reid. Appreciate that. Okay. I'm going to then move on to a question that is asking about the two adjuvanted vaccines, one of which came up in our presentation about Fluad. So Adrina, I think this question might be best for you. So it's saying there was mention in the presentation that there's no studies currently available about how adjuvants may interact, i.e. the adjuvant in Fluad and the adjuvant in Shingrix. So the question is posed around Fluad and Arexvy. Apologies, Reid. Maybe this is a question that's better answered by you, or maybe you can both take turns answering it. So the question is, can Fluad and Arexvy be given together, given that they're both adjuvanted? Or are there any sort of special counseling considerations in regards to administration at the same time of those two vaccines?
I can start, and Reid, if you have anything to add, please feel free to add on to me. So I guess I'll just start by saying that in general, all the influenza vaccines can be given at the same time or any time before and after other vaccines. That is safe to do, and that's why we are okay in recommending co-administration of these respiratory vaccines. When it comes to the adjuvanted product, we don't have studies that are studying head-to-head Shingrix, which is an adjuvanted recombinant vaccine, with the adjuvanted influenza vaccine. And similarly, the RSV vaccines are quite new as well. And so we don't have studies that show head-to-head, with both concurrently administered. Is there anything of concern with the two adjuvant ingredients? So there's nothing really to conclude that it would not be safe to deliver these vaccines concurrently. And so we do recommend that it can be done. Reid, do you have anything to add to that about the Arexvy component?
Yeah, thanks. And the only just one small bit, which is I would just highlight that we talk about the similarity between the adjuvant in Shingrix and Fluad, as opposed to Arexvy being AS01 adjuvant. And so the difference in the adjuvant product itself is something to recognize, and just highlights that these can be safely given together. When adjuvanted vaccines are given at the same time, Dr. Wilson, you did ask, any considerations. I do think as a provider, it would be helpful to mention to your patients or clients that there may be a chance of increased local reactions, mild to moderate, including pain or redness at the site. And so it's something that when we do give adjuvanted vaccines, particularly co-administered, there may be that small increased rate of local reactions or mild adverse events after immunization.
Thanks very much to you both. That's very helpful. So I'm going to turn to a question that's maybe at a sort of a bit of a higher level, and it's asking, what are some of the strategies that can be used to help increase the uptake of annual influenza vaccine? And maybe I can take the moderator's privilege to maybe even expand this further to think about, uptake of all of these respiratory virus programs. And the participant is asking if the presenters and panelists can really explain it in a simple way that could really help with getting this message out to staff members, as well as how the value of the vaccine may be for themselves, but also for families and patients. So I want to turn this question to everyone. And I wonder, as Daniel hasn't yet had an opportunity to weigh in, Daniel, I think this is such a key issue for all of our immunization programs. How do we improve coverage? And I wonder if you wanted to sort of kick us off with some, comments on this, because I know it's a concern to all of us in the immunization space.
Yeah, for sure. Thanks, Sarah. And I wish I had an easy answer because if I did, we would have already done it. So thanks to everybody on the call for doing what you can. It really depends on the space and what we do. So when we're working with particular healthcare provider organizations, we really try to stress the point of protection for themselves and for, patients, everyone they're working with. For many people, that's really helpful. And I think, sharing the data that we have on uptake numbers and what that means in terms of actually seeing cases and outbreaks, for example, is often really helpful. So, we have reasonable data on like long-term care home uptake of our immunizations for healthcare workers, for residents, et cetera. And we can tie that directly to some of the outcomes in terms of the numbers of outbreaks that we see in those settings. And that can be really, really valuable for, I would say the average person who's more on the fence about it and just, maybe tired of getting their yearly flu vaccine, for example. For the group that needs a little bit more, though, it really takes a lot of work from like a trusted healthcare provider to get into the details of the concerns that they have. So to give the example for, last year's Beyfortis program, we talked about it a lot this year already. It was a brand new program. We know a lot of parents had no idea what this was and what to do with it. And really the feedback that we got from, predominantly primary care and obstetrical care colleagues was that it took a really long time to talk to parents about what this is and what it's for and why it's important. So I think we really can't overemphasize how important it is for someone to have a trusted provider that they can talk to. That's why things like even like the Scarborough or Sick Kids vaccine consult lines are so great because they can spend the time to really do it. So at the individual level, that's often what's needed. From the population level, again, as we're talking about, I mean, just sharing the data, sharing the outcomes, that's often really, really valuable for people who just aren't quite sure what they're looking for.
Mm-hmm. Yeah, thanks so much for Daniel. And thanks too for noting those consultation lines. It's a really excellent resource. I'll turn it over to Reid and Adrina if there's anything either of you would like to add to this, I think really important topic about how to increase vaccine coverage.
I might just highlight a couple of resources, especially for having, the more nuanced conversations. So PHO does have a document titled Building Confidence in Vaccines, which kind of outlines some of the best practices around communicating and building trust around vaccination. And the Canadian Immunization Guide also has a helpful guide around communicating effectively about immunization. So those might be good foundations, and you can kind of select what might apply to the patient or group of providers in front of you. But when it comes to, I think the question asked about influenza vaccine specifically, I totally understand that there's fatigue around, something that requires an annual dose. But I think a really simple message is that it's a new vaccine every year. It's a new virus every year. And so it's important to kind of get a new dose every year.
Thanks, Adrina. Thanks for that. Reid, anything further from you on this topic?
Oh, just to highlight the importance of a strong provider recommendation. I think the tricky part, and I'm not pretending this is easy, is balancing that empathetic and listening ear with a strong recommendation. And so it's kind of this assumption that people want to be vaccinated. We know, in most cases with most vaccines, the majority of the population does want to be vaccinated, but may have questions. And Dr. Warshafsky already touched on this, is taking that time is recognize the challenge that's involved there. I think there are likely some very setting specific, strategies. For example, in certain facilities, ideas of having champions within that facility, providing education within that facility. And, I think just on a personal level, something that that has, that I find helpful is we do often see or people quote vaccine effectiveness studies, and they may or may not think that a certain percentage of vaccine effectiveness is something that they would like to, something that's enticing to them. But on the other hand, I think, talking about the vaccine as lessening the severity. And so, should you become ill, and that's a great starting point, not just to avoid hospitalization or avoid an emerge visit, but should you become ill, it's this is the kind of protection that you receive to have a much milder version of the illness. And so I think that's something that a lot of people can also understand, and like I said, could be enticing.
Yeah, thanks for that. Those are all really very, very helpful comments. Um, so I'm going to pick up on a theme of there's been mention of setting specific considerations, and we all know long-term care residents are a really important target group for these programs. So there's a question posed here for us for long-term care residents. At what intervals can vaccines be administered? It's really a question about the interval and whether there be a recommendation for them to be 2 weeks apart is the question mark. And Reid, I know in your presentation you did address some of the, I think, frequent questions around co-administration, recognizing that there's multiple vaccines that are recommended for this population. Can you speak to, maybe remind us of your slide and what it said in terms of if there is an interval, is co-administration okay? Can you help address this query?
Yeah, and I think Dr. Zong mentioned this earlier. Inactivated vaccines can be administered concurrently or co-administered at any time before or after other inactivated or live vaccines. So what that means practically is that RSV, COVID-19, and influenza vaccines can be administered. I will make a note here, and I assume somebody asking this question likely works in long-term care settings. I absolutely recognize that there are some challenges, maybe depending on the setting or the home, that may mean that this is, really difficult. So I think what I can speak to is that the question is, can the vaccines be administered concurrently? And yes, absolutely yes. And we do know that this tends to increase overall coverage for each of those vaccines. And so it is a helpful strategy. It is a powerful strategy, but I don't want that answer to be misinterpreted as diminishing the challenges of having a co-administration strategy in a long-term care home.
Yeah, well said. Well said. Okay, well, thanks for that clarification. So there's a question that I'd like to move us next to. It relates to COVID-19 vaccine and sort of the framing of the recommendations in terms of, I guess the way the question is posed is whether the COVID vaccine is recommended for those who are not at high risk. And Reid, I know in your presentation you included a lot of nuance around may and should and groups in terms of prioritization. So just wondering if you can maybe summarize, for those who are not in a high risk group, are they still recommended to receive COVID-19 vaccine? And after we hear from you, maybe I can turn to Daniel for your perspectives on this. What is recommended for those who are not in an identified very high risk group for COVID-19 severity?
Yeah, and thanks for highlighting some of the challenges around language and in vaccine policies. So yes, individuals are still recommended to to receive a COVID-19 vaccine. Part of the reason that certain language such as should or may is used is to describe the sort of conversations that may take place. And thanks for everybody for attending. The providers that speak with patients at an individual level. This really highlights that, maybe what I should have started with is that we do have evidence, including from last year, of the effectiveness, as I mentioned, of the COVID-19 vaccine in all populations, but also including, and I highlighted those 60 and over because of the known potential for severe disease in that age group. But we do have evidence of effectiveness, with last year's vaccine in the general population. And so happy for Dr. Warshafsky to take it from there, but just to say that we do have that effectiveness, those effectiveness studies. And we do know that that individuals who are not at increased risk may wish to have just some more detailed or nuanced conversations with their providers. And that's why some of that language is used.
Thanks so much for that, Dr. Morrison. Daniel or Dr. Warshafsky, is there anything you'd like to add to that?
Yeah,
Just this piece around communication and may and should and who's recommended, who's most strongly recommended. Interested in your thoughts.
Yeah, and we'd covered the details and the evidence for the product, so I won't go over that and agree entirely. Our language is consistent with NACI about shoulds and mays, but the still recommendation on here is everybody should get it. Like, it's beneficial for everybody to get your COVID vaccine, same as to get your flu vaccine, even if you're not likely to go to a hospital or be really sick. Even if it just means you have a fewer days of being really sick with COVID at home, that's still a benefit. I mean, I think it's a benefit. I'd rather not be sick at home with COVID. So like broadly speaking, Ontario is suggesting everybody gets their seasonal vaccines, all of them. But it's really, to Reed's point about really trying to emphasize for those especially high risk groups, like you really, really need to get it because we want to avoid those severe outcomes like hospitalization or worse. That's really the key.
Yeah, thanks so much for that. Okay, and thanks to you both, of course, for those comments. And I think those are very, very helpful responses. So I'm going to just, again, take us back to this Q&A pod and see there's still a variety of interesting questions that are continuing to come in and really appreciate our participants for sending these along. So Reed, I'm going to send a question your way, and it relates to the RSV program in relation to protection of infants. And so it's really asking about really, so I'm going to read it to you. It's asking for clarification in terms of if a baby is born at less than 37 weeks, even if the pregnant person has received RSV immunization in pregnancy, if it's been more than 2 weeks. It's, I think, really asking for clarification about, what to do for around the recommendations for the management of an infant whose pregnant mother or individual has received RSV vaccine. So maybe, I believe you had this information in the slide, but maybe you could just clarify sort of what is said there in terms of to address the scenario where someone's received the maternal vaccine in pregnancy.
Yeah, thanks. Great question. And maybe I'll just expand the question a little bit.
Please.
So, if a pregnant person receives the vaccine and they deliver less than 2 weeks after receiving the vaccine, as I mentioned, it takes about 2 weeks for protection to be transferred to the infant. And so in that case, nirsevimab administered to the infant would be recommended to ensure that there's protection. In the case of, and I think maybe what the question is getting at is that if a pregnant person receives a vaccine and delivers prematurely, even if it has been 2 weeks since receiving the vaccine, then that premature infant in their first year is recommended to receive nirsevimab because of the increased risk of RSV disease in their first season. That group, babies who are born premature have not been shown to be at increased risk without other comorbidities to be at increased risk in their second RSV season. And so that those babies who are born premature would not be included in the quote unquote high risk children group that would receive another dose of nirsevimab in their second season. So I hope that clarifies it.
Maybe I can also add a
Yeah.
teeny bit in, because some of it I think is the language that we've used in our guidance that does this. So for anyone who's familiar with the Synagis program, premature infants were specifically called out as should receive Synagis in their first year of the season. Because we now have a universal program, they're not called out special as high risk in that second year high risk group. But to Reed's point, they are certainly still high risk in their first year. And the additional benefits from Beyfortus, and at least what we know so far in terms of the effectiveness, means that they should still get that as the best protection for their first year. But again, the reason that it kind of looks funny is because we don't have them listed high risk anywhere else in the guidance. So hopefully that helps clarify a bit.
Yeah, that's great. Thanks so much to you both. Really, really helpful. So I'm going to turn next to a question that I think is very interesting. It's pointing to MMR vaccine and how it protects against measles, mumps, and rubella, and reflecting on the fact that we're talking about three seasonal respiratory viruses: RSV, COVID, and flu. Is there a chance that maybe at some point in the future there might be a vaccine that would include all or some of these viruses? And the participant is, I think, wisely noting that this could help with vaccine hesitancy and uptake. But interested to hear thoughts from our panelists today about where this might be going.
I can jump in first because
Sure.
the regular updates from the manufacturer, what's happening. So, I mean, there certainly are several combination vaccines that are in various phases of trials right now. There's like COVID flu combos, there's RSV human metapneumovirus, there's like a couple different combination ones that are out there. I think the latest we know that they're still probably all at least a couple years away before anything is actually available. And obviously some that will depend on Health Canada authorization of products. I mean, to the point about maybe it'll help uptake is a great question, because I don't really know. Like, maybe it will, maybe it won't, right? I don't think we'd be comfortable having only combination products, because then people who don't like one or the other will suddenly not get any vaccine. But I do agree that, if we were able to have multiple different products, some single, some combination, it probably would help in a lot of situations for people who just don't like getting multiple needles, for example, and increasing some of our uptake and promoting a bit of both of them. But I think it's a very complex question in terms of how much it would actually help our overall uptake, and really, really interesting to look at that.
Yeah, absolutely. Great. Well, thanks so much for that really helpful response. Okay. I think we might have really just a moment now just for our, one or two final questions. And I want to take us back to at the beginning of our Q&A period, we emphasized that the recommendations for RSV vaccines for older adults is a one-time lifetime dose, at least at the present time. And so there's a question that's posed about whether there'd be any risk with administering RSV if someone has previously received a dose in the past. So that's the way the question is framed.
Yeah, good question. One of the documents that Dr. Zhang pointed to earlier about increasing the confidence in vaccines when talking with patients, one of the points that document makes is having those kind of nuanced conversations about risks and benefits. So this is a really good question. It's not so much about the risks as it is the benefits in this scenario. And so when we look at the vaccine clinical trial data of, for example, those who have in these clinical trials, they have tested booster doses at different intervals. So, for example, a second season booster dose or a third season booster dose and so on. It just doesn't appear to have the same sort of benefit as and said otherwise, is that there's not a meaningful difference for those who receive a booster dose as compared to those who did not, or a significant difference or a significant benefit. And so in this case, while there may not be the quote unquote risk of administering another RSV dose, what we do know is that from in discussion with the patients and from a justification point of view, the same benefits do not exist. And so it doesn't provide additional protection of the data that we have currently for 3 years or 3 seasons. It doesn't provide that additional benefit of giving a seasonal dose or a booster dose right now.
Okay, thanks so much, Reid. And I think you've noticed more to come on this topic, right? It's certainly an emerging area of research and investigation. So I'm looking at the time is 12:59, so I'm going to close our session today. First, I'd like to thank our presenters and our panelists. So thank you so much, Dr. Morrison, Dr. Zong, and Dr. Warshafsky. I think the presentations were excellent and really appreciate all of the helpful responses in this dynamic Q&A. As I mentioned at the beginning, this session will be posted on the PHO website in terms of the recording as well as the presentation deck. So watch our website. That will follow shortly. And for those of you who have joined us, you'll soon receive an online survey requesting your feedback on the session. We really value your feedback in terms of how we can improve our programming moving forward. So we really encourage you to fill that out. And just wishing everyone the rest of the day, hoping everyone has a very good rest of your day. And thanks again for joining us. Bye-bye for now.